From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You are listening to JAMA Clinical Reviews. Thank you for joining us. I am your host, Dr. Mary McDermott, Deputy Editor of JAMA, and I'm here today with Dr. William Chey. He is President of the American College of Gastroenterology, and he is Division Chief at the University of Michigan in the Division of Gastroenterology and Hepatology. Dr. Chey is author of a new JAMA review on the topic of chronic non-infectious diarrhea. Thank you for joining today, Dr. Chey.
Thanks. Glad to be here.
I wonder if you could lead us off by telling us what is chronic diarrhea? How is it defined?
Chronic diarrhea is really defined by loose to watery stool consistency. And that may or may not be accompanied by increased stool frequency, symptoms like urgency, or even fecal incontinence. But the real cardinal feature is that loose to watery stool consistency for greater than 4 weeks.
And how common is it?
It's actually surprisingly common. Probably somewhere between 6 to 7% of the U.S. population actually suffers with chronic diarrhea. That equates to 22, 24 million people.
And can you talk a little bit about what are the most common causes of chronic diarrhea?
By far and away, the two most common causes of chronic diarrhea are irritable bowel syndrome with diarrhea and functional diarrhea. These are both disorders of gut-brain interaction that are defined by the presence of diarrhea, and patients with IBSD also have abdominal pain or discomfort. Patients with functional diarrhea typically don't have abdominal pain or discomfort, at least as one of their predominant symptoms.
Okay. I wonder if we could discuss the evaluation of the patient with chronic diarrhea. When you see a patient coming in with symptoms of chronic diarrhea, what are the history questions that you typically start with?
It's really important to understand what the patient means by diarrhea. Obviously, we're focused on that loose to watery stool, but a lot of times the other symptoms are really affecting the patient's quality of life and ability to function on a day-to-day basis. So, for example, how often they're moving their bowels, whether they're suffering with that fecal urgency, that intense sensation of feeling that you're going to need to move your bowels, which can be so debilitating for some patients. And the worst of all the symptoms, fecal incontinence, that's really important to understand. It's also important to think about asking questions that can help you to characterize what type of diarrhea a patient is having. So, for example, is the diarrhea worsened after eating a meal? And conversely, does it go away if you fast? That would suggest some type of maldigestion or malabsorption related process, an osmotic form of diarrhea. On the other hand, if you ask and patients say that their diarrhea is not affected by fasting or eating a meal, that would steer you more in the direction of a secretory form of diarrhea, particularly if a person is having diarrhea at night, diarrhea that awakens them at night.
And what is the most common cause of non-infectious secretory chronic diarrhea?
Yeah, I think that the two diagnoses that really come to mind as being most likely are bile acid diarrhea, which is surprisingly common. Remember that bile acid diarrhea is a lot more common in individuals who have undergone a cholecystectomy or have undergone a terminal ileal resection. It even turns out that amongst patients diagnosed with IBS and diarrhea, that up to a third of those patients will have evidence of excess bile acids in their stool, suggesting bile acid malabsorption. So bile acid diarrhea is a really common cause of secretory diarrhea. The other big one is microscopic colitis. In fact, if you have a patient that comes in with unexplained diarrhea and reports that their diarrhea isn't solely related to eating or is occurring at night, particularly in an elderly woman, and particularly if the diarrhea is associated with the start of a new medication, like a proton pump inhibitor or a nonsteroidal anti-inflammatory medication, for example, or certain antidepressants, those would be patients where you'd have a really high suspicion that they're suffering with microscopic colitis. And of course, the diagnosis is made through doing a colonoscopy with random biopsies, looking for specific types of inflammation and or a thickening of the basement membrane that could be suggestive of a specific form of microscopic colitis called collagenous colitis.
And when you're evaluating someone presenting with new chronic diarrhea, do you do blood testing? And if so, what type of testing?
Yeah, so I think there's a reasonable battery of testing that should be done in every patient that presents with chronic diarrhea. So it's a great idea to do a complete blood count to make sure there's no evidence of unexplained blood loss or anemia, particularly iron deficiency anemia, which raises all sorts of red flags. A comprehensive metabolic profile just to make sure that the electrolytes are in check. Many advocate thyroid function studies, so at least the TSH to look for hyperthyroidism. It's important to remember that diarrhea associated with hyperthyroidism almost never presents as only diarrhea. There will be other signs and symptoms to suggest the presence of hyperthyroidism. But nonetheless, if any of those other symptoms are present, it makes sense to do a TSH to make sure that it's not hyperthyroidism. In addition to that, you should think about doing a fecal calprotectin examination. And that is a really good screening test for inflammatory bowel disease. Patients that have a normal fecal calprotectin test have an extremely low likelihood of having inflammatory bowel disease. So it essentially rules it out in patients with chronic diarrhea. And finally, every guideline recommends that in patients with chronic diarrhea, you also do serological screening for celiac disease. The American College of Gastroenterology recommends doing that by ordering a IgA tissue transglutaminase antibody test combined with a quantitative immunoglobulin A study to make sure there's no evidence of IgA deficiency.
Is IgA deficiency more common in celiac disease?
Yeah, it turns out it is significantly more common. It's been estimated that somewhere between 2 and 4% of celiac patients have evidence of IgA deficiency. And of course, for the listeners, the reason why that's important is because most of the screening tests that we do for celiac disease are IgA antibody tests. And so if you're IgA deficient and you have celiac disease and you, of course, are screening or testing for celiac disease with an IgA-based test, it'll come back as falsely normal, even in patients that have celiac disease.
And if someone's presenting with chronic diarrhea and they do have iron deficiency anemia, is celiac disease presumably the most common, or are there other diagnoses you're thinking of?
It depends on the type of patient you're dealing with, but celiac disease is certainly very high up on the differential diagnosis. But, if you're dealing with particularly a person over the age of 45, you need to be very aware of the possibility of colon cancer. So anybody over the age of 45, we recommend undergo some form of colorectal cancer screening. But a person with iron deficiency anemia and chronic diarrhea should undergo a colonoscopy and probably an upper endoscopy with biopsies of the colon and small intestine.
Your review talks about other criteria that warrant endoscopy. Can you just summarize who else?
Yeah, so anybody that has so-called concerning signs and symptoms. So individuals who report blood with their stool should undergo a much more detailed and rigorous evaluation, certainly with endoscopy and other tests. Also, individuals with unexplained weight loss and chronic diarrhea should also undergo a full endoscopic evaluation. Individuals that provide a history that is concerning for the possibility of steatorrhea, so large, bulky, floating stools and weight loss should be evaluated with endoscopy. And in particular, that in individuals with potential steatorrhea, you're thinking and you're concerned about the possibility of a small intestinal process. And there you'd want to be absolutely sure, in addition to a colonoscopy, that you get an upper endoscopy with small bowel biopsies. And then the final thing just to mention is if an individual has a family history of certain diseases that are increased in risk if you have a first-degree relative, things like celiac disease or inflammatory bowel disease or colon cancer, again, you should be more aggressive in your evaluation.
Great. Now, your review talks about using history to help distinguish between small bowel and large bowel causes of chronic diarrhea. Can you talk a little about that, please?
Yeah, there are definitely clues that you can get. The first thing to say is that history is sadly imprecise. Like it'd be wonderful to say if you get this history all the time, it's going to turn out to be this particular diagnosis. Unfortunately, in clinical practice, it just doesn't work that way. And there's a lot of overlap between all of the different etiologies of chronic diarrhea. That said, there are definitely certain features that should make you think about certain diagnoses more than others. So, for example, we talked about that issue about meal-related chronic diarrhea and nocturnal diarrhea, so I won't go over that again. But what I will talk about is individuals with a history of other autoimmune disorders. So let's say, for example, a person has a history of thyroiditis or Sjogren's disease or lupus or type 1 diabetes mellitus. Individuals with chronic diarrhea and other autoimmune diseases are at increased risk for autoimmune-related forms of chronic diarrhea like celiac disease or microscopic colitis. So that should be a tip-off, and you should sort of think about that sooner than later. Also, I think I mentioned this earlier, but I'll mention it again because it's a really important point. If a person's diarrhea is temporally related to the start of a new medication, in particular, things like proton pump inhibitors, nonsteroidal anti-inflammatory medications, selective serotonin reuptake inhibitors, but virtually any type of medication, you should be thinking about the possibility of microscopic colitis, and those patients should undergo a colonoscopy with random biopsies. Also, if an individual has a history of small intestinal dismotility, and that's more common in individuals with diseases like scleroderma or chronic intestinal pseudoobstruction, those patients are at dramatically increased risk for developing small intestinal bacterial overgrowth, which of course is at least temporarily treatable with antibiotics. And the last thing I'll mention is that individuals with chronic diarrhea, particularly those that develop chronic diarrhea following a surgical procedure like cholecystectomy or terminal ileal resection, are at dramatically increased risk for bile acid malabsorption and bile acid diarrhea, which again is quite treatable with bile acid sequestrant medications like cholestyramine, cholestyramine, or cholesevelam.
Great. That was so informative. You mentioned small intestinal dismotility. What is that exactly, and how is it diagnosed?
If you think about normal physiology, if you think back to medical school and when we learned about the migrating motor complex, which is in the fasting state, that rhythmic set of contractions that occur starting in the stomach, going to the small intestine, and then terminating in the colon, that actually serves as a housekeeper function. So it actually sweeps remaining debris out of the small intestine and helps to keep that environment clean and prevents the development of small intestinal bacterial overgrowth. Well, if you have either suppression or abnormalities in that migrating motor complex, you lose that housekeeping function, and it promotes stasis of material in the small intestine, which can serve as a nidus for the growth of bacteria and lead to the development of small intestinal bacterial overgrowth. So if you have abnormal motility, or let's say you've undergone previous pelvic or abdominal surgery and you have adhesions that lead to either tacking down of the small intestine so it's not freely mobile, or even worse, partial obstruction, which leads to the inability of materials to flow smoothly through the small intestine, all those things are going to predispose to a greater likelihood of developing small intestinal bacterial overgrowth.
Great. I want to talk a little bit about irritable bowel syndrome and functional diarrhea, because as you said at the outset, those are the most common causes of chronic diarrhea. Can you talk a little bit about what those conditions are and how they should be diagnosed and how you treat them?
Yeah, so they're so-called disorders of gut-brain interaction. And the name is intended to make clear that irritable bowel syndrome and functional diarrhea are both conditions that arise from a heterogeneous group of abnormalities that affect the gut and the brain. In other words, I think a good way to think about this is that DGBI, like IBSD or functional diarrhea, are not a single disease. They're symptom-based diagnoses, syndromes that are likely to be of varying pathophysiological abnormalities. People talk about abnormalities in motility, intestinal permeability, immune activation, small intestinal and colonic microbiota, so-called dysbiosis, as well as psychological factors and genetic factors. And you can see I've just rattled off 7, 8 different things that can all lead to the same symptoms. And varying combinations of abnormalities in those, what I refer to as pillars of the pathophysiology of these conditions, likely play a part to different degrees in different patients. And so again, it's not one disease. It's probably a number of different diseases for which we don't currently have accurate biomarkers that present with the same symptoms. Now, people argue a lot about whether these are quote unquote diagnoses of exclusion. In a way, they are a diagnosis of exclusion because, as I mentioned to you in the beginning, we do a CBC to rule out things that cause anemia. We do a metabolic profile to make sure that there aren't electrolyte abnormalities suggestive of certain causes of chronic diarrhea. We rule out celiac disease and inflammatory bowel disease. So we do exclude a number of things, but we're really playing the odds in that circumstance. So what we're doing is we're excluding the most common things and things for which we have different means of treating patients that we identify with celiac disease, inflammatory bowel disease. Obviously, we don't treat those the same as we treat patients with irritable bowel syndrome or functional diarrhea. So if patients fulfill the characteristic symptoms of IBSD or functional diarrhea and they have negative baseline testing for those other abnormalities, we say that the greatest likelihood is they're suffering with IBS and diarrhea or functional diarrhea, and then we recommend empiric treatment for IBSD and or functional diarrhea. And that typically consists of over-the-counter medications like mu-opioid agonists like loperamide, prescription drugs like diphenoxylate atropine, anticholinergics, so drugs like dicyclamine or hyoscyamine, which are prescription medications, bismuth, which we oftentimes will use as a treatment for patients with diarrhea, and even 5-HT3 receptor antagonists like ondansetron or granisetron, which have very powerful antidiarrheal properties. And if a patient doesn't respond to those first-line therapies and they have abdominal pain or discomfort, so they have IBSD, there are prescription medications like rifaximin or eloxatiline that you can think about using. And Mary, I should have started by saying that an important part of this is also dietary and lifestyle recommendations. I think that from a diet standpoint, we oftentimes will think about the use of something called the low FODMAP diet, which is a diet that reduces the intake of fermentable carbohydrates that are hard for your small intestine to digest or absorb. And for that reason, they get to the colon where they're fermented, producing short-chain fatty acids and gas, which can trigger symptoms in patients with IBSD and functional diarrhea.
And what are those foods that are part of the FODMAP diet to be avoided?
It's actually a comprehensive list, so I'm only going to be able to provide just a very small number of examples. But some examples include oligosaccharides like legumes. Those are galacto-oligosaccharides that are impossible actually for humans to be able to break down in their small intestine. Disaccharides, which are things like lactose. Monosaccharides, and a great example there is fructose. And then polyols, which are sugar alcohols, so things like sorbitol or mannitol, which again are very difficult for the human small intestine to break down and absorb.
I'm Mary McDermott, and I've been speaking today with Dr. William Chey about his JAMA review on the topic of chronic non-infectious diarrhea. You can find a link to this article in this episode's description. For more of our podcasts, please visit us at jamanetworkaudio.com. You can subscribe and listen wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.